This video is about shoulder evaluation using special tests to go along with your subjective and objective observation and palpation for making a rough diagnosis on what tissue is pathological. The goal of this presentation is to review clinical diagnostic tests of the shoulder, how to do them correctly according to the literature, and how to put them together into your clinical decision making. There's a million tests out there. Here's a list of all the ones that I saw in the research for the shoulder, and we're going to decide which ones are the best based on sensitivity and specificity and how to put them together to make your decisions. So why do we even care about special tests? Why are they useful to us? One is for communication. It is a lot easier to name a special test and to say, I took some player into abduction, external rotation with forceful contraction of the biceps, and it caused pain in the anterior shoulder. It leaves a lot open for interpretation. Why can't we just send the player for an MRI? That'll tell us what structure is a problem. Well, 79% of asymptomatic throwing athletes have been shown to have labral pathologies, 40% to have rotator cuff tears. Special tests can help you identify what is causing the pain, and this in conjunction with imaging can help decide the course of medical management. The purpose of special tests is to see what structure is causing the pain, not is the structure somehow abnormal. Referred pain is also common in the shoulder. We need to make sure that we know what structure we're dealing with, what is causing the pain. That'll help us get rid of some red flags and narrow down what we're dealing with. Finally, treatment strategies. You need to know what tissue you're dealing with when you're going to do a rehabilitation. Am I dealing with a labrum that's not going to get any stronger, that might need surgery? Am I dealing with an inflammatory process? Am I dealing with a muscle? All these things are going to change the way you do rehabilitation and structure what tissue you focus on. Keep in mind when we're talking here, we're trying to identify the pathological structure, but the causes of the problem could be numerous. Mechanics, muscle imbalance, scapulothoracic dysfunction, poor kinetic chain energy transfer, lack of joint rotation, joint range of motion, a pelvic and nominant rotation. There's a million different things that can cause these problems, and with these special tests we're just trying to figure out what tissue we're dealing with. What's the problem? And then we'll figure out how to solve it and keep it from coming back. So how do we test which special tests we're going to use? Well, we got to go to the research. The strength of the article is the first thing you have to look at. Look at Pedro, Quadus 1, Quadus 2. They're good ways to see how strong the article is. Then, does the population match your population? I like to look at overhead throwing athletes when I'm looking at the shoulder, so I got to make sure that the study was done in an active overhead throwing population. Next is stats. Sensitivity being a good screening, sensitive test being a good screening tool, a specific test being a good tool to identify what tissue is pathological. Likelihood ratios you can't forget about either, and the positive likelihood ratio is something we're looking for that's going to be over 10, and a negative likelihood ratio is going to be under 0.1. But I'm not going to talk about them much here, even though I do consider them when I read articles. A good way to kind of cheat the system a little on this is, if you see on the bottom here, there is a these are two tests with the same sensitivity. As long as your specificity is over 40, or the other number is over 40, so it works both ways, that means your likelihood ratio is going to be pretty high. So your odds will increase. So in this case, your odds increased 50% that you're dealing with that tissue on the test on the left, whereas only 10% on the test on the right, even though the sensitivity was the same. So again, sensitivity, if it's high, make sure your specificity is at least 40, and vice versa. If specificity is high, make sure your sensitivity is at least 40, and you'll have a good likelihood ratio that goes along with it. So, a sensitive test greater than 80 is a good screening tool. Sensitive negative test rules out the pathology, so it's not something that you need to deal with. So your acronym for this is sensitive test that is negative rules out, or SNOUT. A specific test over 80 is a good diagnostic tool. A specific positive test rules in the structure. Okay, so here's your acronym for this. A specific positive test rules in the pathology. So SPIN. So sensitive, SNOUT, specific, SPIN. Good way to remember these. So how does this all fit into your evaluation? Well, you're going to start with a sensitive test. That's your screening test. It's going to either be positive or negative. If it's negative, it rules it out. You don't have to worry about that being the pathological structure. If it's positive, that means that we need to go on to the next test, the specific test. The specific test is what's going to rule in our tissue. So that's either positive or negative. If it's positive, it rules it in. That's the tissue we're dealing with. That tissue is causing the pain. If it's negative, it's still possible. Now, unfortunately, here we have to go back to the last step and maybe look for other possibilities. This might be where you're stuck and maybe have to resort to MRI or something along those lines. So when we're looking at the shoulder, the main differential diagnosis that we're looking for is slap tear, internal impingement, which actually slap tear falls under internal impingement, external impingement, also known as subacromial impingement, supraspinatus at pathology, rotator cuff, so your external rotators, basically teres minor and infraspinatus, your subscapularis specifically, any general instability, either anterior or posterior typically, and then biceps tendon pathology. So we're going to start with the slap tear. Good little picture here from the internet of the glenoid labrum being torn off by that biceps tendon. So the first test we're going to talk about is for slap tear. The dynamic labral shear modified version is a good test with a high specificity of 98 and a good sensitivity of 72. This test is done by the examiner elevating the arm to 120 degrees in the scapular plane, externally rotating to tightness with the elbow flexed to 90 degrees. This position is maintained while the arm is lowered from 120 degrees to 60 degrees of abduction. So positive test for this is either pain, a click, or a catch. So you're catching the labrum as you lower the arm. The next test is the passive distraction test for slap tear. The patient is supine on the table. The arm is passively abducted to 150 degrees in supination. The humerus is then humeral position is then maintained, and the forearm is supinated. You can see how this would place traction on the biceps onto the labrum. We're looking for deep shoulder pain here. Next test for slap tear is the O'Brien's or active compression test. This is originally designed for slap tears. The patient is standing, shoulders flexed to 90 degrees, and then 15 degrees of horizontal adduction. The shoulder is internally rotated and a downward force is applied. Then, the same position, the shoulder is externally rotated and a downward force is again applied. If there's more pain in the first test with internal rotation and it's reduced with external rotation, this is a positive test. The reason I bring this test up is it's well known and highly taught, but the numbers actually aren't very good, really, with a 67% sensitivity, 37% specificity, and although it will show later that it's helpful on other pathologies, for slap tear this might not be a good go-to test, but important to know because you'll see it out there a lot. Next thing we're going to go over is how to do some tests for internal impingement. So this includes some slap tears, but especially the underside of the supraspinatus, as well as the biceps tendon. The first test for internal impingement is the posterior impingement sign. This test has a specificity of 100%, a sensitivity of 95%, but probably more research is needed to make sure that we can verify those numbers. The patient is put in supine, the shoulder is abducted, slightly extended, and maximally externally rotated, all passively. So the biggest difference between this and an apprehension type test is, of course, the posterior force on the humerus and then the slight extension of the shoulder. Positive for this is posterior pain in the shoulder. Next is the internal rotation resistive strength test. Patient is standing. The arm is abducted to 90 degrees in the scapular plane and 80 degrees of external rotation. The elbow is flexed to 90, of course, and there's manual muscle testing done of the external rotators and the internal rotators. Positive test for this is strength in external rotation and weakness in internal rotation, which of course is opposite of what you would expect. Again, high numbers and probably needs some more research to be done, but a specificity of 100% and a sensitivity of 95%. External impingement. So this includes your subacromial impingement, your rotator cuff muscles, anything underneath the acromial, anything in the subacromial space. So this is our very well-known Hawkins-Kennedy external impingement test. Patient can be standing, also can be done in supine. The shoulder is in 90 degrees of flexion, elbow at 90 degrees of flexion, and the examiner internally rotates the shoulder while palpating the scapula. So the scapula can't move on this, we just need to move the humerus, basically banging it against the acromion, narrowing the subacromial space. So for this test, it's positive with pain. And again, the numbers aren't great for this. Some studies are showing a decent sensitivity. This is the empty cant test for external impingement. Remember that the supraspinatus is involved in these, so this looks a lot like a supraspinatus manual muscle test. The patient is standing, arms elevated in the scapular plane to 90 degrees with full internal rotation. The examiner gives a downward resistance, and we're looking for weakness on this one. So this is important. In this one, you're not looking for pain, you're looking for weakness. Pain can be around, but weakness is the positive test. And they've done some studies on this to show that pain is not a good predictor. It needs to be weakness. So rotator cuff tears. How are we going to test the rotator cuff? Well, same thing. Here it comes again, except this one's the full cam. So this is the exact same test, except the thumbs up. So we're basically externally rotated instead of internally rotated. But look at here. This is positive with pain, weakness, or both. So pain or weakness. It has a sensitivity of 86%, specificity of 57%. So again, you got to remember what you're looking for all these tests. Here's a supraspinatus test that, if you have a full tear, is going to be positive. The patient is unable to control the descent when the arm is abducted to 90 degrees. So the examiner abducts the arm to 90 degrees and just lets go. The patient is instructed to control the descent. This test sensitivity isn't great, but specificity is 92 to 93%. This is the external rotation lag sign. The examiner stands behind the patient, arms in 20 degrees of abduction, and elbow flexed to 90. The examiner fully externally rotates the arm, not to tension, but just before tension, because you'll get a false positive if you externally rotate the arm too far because of elastic recoil. The patient is instructed to maintain this position. I say, I'm going to let go, maintain this position, and a negative is that the patient is able to hold it there. A positive, the patient can't maintain it, it'll bounce back. This is the lateral joke test for general rotator cuff tears. So the patient is standing, the patient abducts the shoulder to 90 degrees and internally rotates to 90 degrees, which is actually a pretty good feat in of itself. So I assume that this also means that you just pretty much fully internally rotate the arm. The elbow is flexed to 90 degrees. The examiner applies an inferior force to the distal humerus. So, and this one's positive with pain or weakness. So either one, pain or weakness. Specificity of 89, sensitivity of 81. The belly off test for subscapularis. Patient is seated. The examiner is in front of the patient. The elbow at 90 degrees of flexion and the hand placed on the stomach, with the wrist straight and shoulder passively flexed past the body. So if the patient is unable to hold this position, the wrist flexes or lifts off the belly, or the elbow falls behind the body, all positive for weakness of the subscapularis. This is the lift-off test. So the lift-off test is good for certain fibers. I believe it's the inferior fibers of the subscapularis. But a lot of times the patient won't be able to get into this position without pain. So that's one of the downfalls of this test. Patient is seated or standing, puts his hand on his lower back and lifts it off, increasing internal rotation. Belly press, again, same kind of test. Patient is sitting, the elbow at 90 degrees of flexion. Press on the stomach by internally rotating the shoulder. And when the patient is pushing on the stomach, the elbow drops behind the body. It suggests that the patient needs the lats to extend the shoulder instead of internally rotating, suggesting subscapularis weakness and possible tear. So here's some tests for instability. And this is your apprehension and job relocation test plus the surprise portion. So all three tests in one. The cluster shows good numbers. All these tests individually, not so great, but when you do all three and all three are positive, your specificity is 100%, sensitivity is 40%. So patient is in 90-90 position, examiner applies a posterior force to the humerus, and then the force is released. So the apprehension is putting the patient in that position. The relocation is putting the hand on the shoulder, and the surprise is when you let go and they have apprehension. What we're looking for this is a recreation of the feelings of apprehension or instability at the beginning. So they should say, oh, that's how I feel. I feel like that is my instability. That's my main symptom. The biceps is a test, has a couple tests that are just okay. And this is the best one according to the numbers, the uppercut test. Pretty much put the elbows at 90 degrees of flexion, the forearm is supinated, the patient makes a fist and uppercuts up to the ceiling, and the examiner resists the force. Increased pain or pop over the shoulder is what we're looking for a positive test, with okay numbers with a 78 specificity and 73 sensitivity. This is the famous speeds test for bicep pathology. The patient flexes the shoulder to 90 degrees, and the examiner resists shoulder flexion. So this is an eccentric force, an eccentric shoulder flexion force that is being resisted, and a positive test for this is pain in the bicipital groove. That was a lot, I know. But how do you put them all together into an evaluation? Well, we go back to this chart that we talked about earlier. Start with the sensitive test, go to the specific test. If both are positive, then we can rule in that there's a pretty good chance that that's the tissue you're dealing with. So when you look at the labrum for slap tears, the best sensitive test is really a Job plus a palm-up test plus the O'Brien's test. So although the O'Brien's test by itself, we were saying, wasn't that great, when you cluster it with the Job test and the palm-up test, you have a good sensitive test. So if that's positive, then we go to the dynamic labral shear. Those two are positive, there's a good chance we have a slap lesion. For internal impingement, we're going to start with the internal impingement sign. It has a good sensitivity. If that's positive, we go to the internal rotation resistance strength test. Those two are positive, we have a good chance of dealing with internal impingement. So for external impingement, we're going to start with Hawkins Kennedy. Although the numbers aren't great, according to the research right now, it's the best test that's out there for screening. If that test is positive, we're going to go to the anti-can test. So remember that when we're putting all these together, this little algorithm here can work for your knee special tests, ankle special tests, whatever special test you want. You can put your own shoulder tests into this algorithm if you want. Supraspinatus, we're going to go from the full can to the drop-arm test. For the infraspinatus and the teres minor, we're going to start with the external rotation lag sign, and we're going to end with the external rotation lag sign. A good test for both. Subscapularis, we start with the belly off, and we're going to go to the lift off. A great screening tool for the AC joint is just palpation of the AC joint. If the AC joint isn't tender, you probably don't have any AC joint pathology. That's not always true with other pathologies, for example, biceps pathology, where palpation isn't as sensitive or specific as you would think that it might be. So we're going to palpate the AC joint, then we're going to go to the O'Brien's test. So remember again, the O'Brien's test wasn't good for slap tear, but when it comes to a specific test for the AC joint, it's a very powerful test with a 90 to 97% specificity. Instability, start with the Job relocation, and we go to the cluster with the apprehension, relocation, and surprise. So in general right here, you can just do the apprehension, relocation, and surprise, and that's a pretty specific way to rule in some kind of instability. And remember, we're looking for the recreation of those instability symptoms that were described. Remember, we're not looking at laxity, we're looking at that symptom of instability. So the ability to sublux the shoulder may be normal in a lot of people. 125 of 246 asymptomatic male athletes' shoulders were looked at by McFarland in 1996. 21% could be subluxed anteriorly, 54% posteriorly in the Minter 96 study. 66 of 123 male athletes showed a positive sulcus sign in that McFarland article, and that's of grade 2 or 3. Also, there's poor inter-rater agreement and intra-rater agreement when you're looking at laxity in general. So even when you're looking at you versus someone else, or you versus you, from one day to the next, you can't measure the same amount of laxity in the same shoulder. So how do you put it all together? Take your list of differential diagnosis, run them through your sensitive tests, come up with what's possible, then you look for what's probable by putting it in your specific test. Don't forget though that rotator cuff there in the possible line is still possible, just not as probable as your labrum and biceps. This brings up a good point that you can also have multiple pathologies, and a lot of times will. So don't just hang your hat on the first one you see. You got to test all of these. Thanks for listening. Hope you got something out of this shoulder evaluation little talk. Come check us out at www.nextwavept.com. I'm Nick Conti. Thanks again.